Good afternoon. My name is Marina Basilevich, and I am an associate professor of anthropology here at Luther College. I am also involved in the global health program since my research interests are largely in the medical anthropology realm. Today, I want to talk to you about the insights that anthropology and global health could provide to us while we are trying to make sense of the pandemic. My talk today will focus mainly on three issues. First, what we can learn from the critical medical anthropology about the concept of the outbreak itself. I will also try to connect my observations from a research site in Ukraine that I've had for the last couple of decades, and also what we can learn from anthropology in regards to the public health interventions. I should also say a few words about the disciplines that I'm talking about today, anthropology and global health. Anthropology is the study of human diversity, past and present, and the application of that knowledge to help people of different backgrounds to better understand one another. Medical anthropology is one field of anthropology, and medical anthropology focuses specifically on human health problems, as well as our ideas about wellness and well-being cross-culturally, and the healing systems that we've come up with in order to address our general life cycle issues as well as instances of sickness. Anthropologists do this work in broad social and cultural contexts, and lately many anthropologists have been involved in the public health efforts domestically and abroad, so they do not just engage in academic research, but also in applied research that contributes to understanding and improvement of human health and health services worldwide. Medical anthropology is used in public health efforts in order to understand complex issues and think about realistic solutions within a critical, holistic, and culturally informed anthropological framework. Global health is an interdisciplinary field that has emerged in the last several decades. In the past, it was known as international health. It's the area of study, the area of research, and the area of practice that basically places a priority on improving health and achieving equity in health for all people worldwide. So global health doesn't necessarily mean the study of other people's health, people who live somewhere far away. It's really for everybody. Global health is a look at health disparities and understanding why they exist at home and abroad. While there are many theoretical approaches in medical anthropology, today I will talk from the perspective of critical medical anthropology. Critical medical anthropology suggests that political, economic, and cognitive structures constrain individuals' decisions, shape their social behavior, and affect their risk for disease. From the perspective of critical medical anthropology, it is essential to not look at the viral spread just from the perspective of viral contact. In her recent book, Contagious Cultures, Carriers, and the Outbreak Narrative, Priscilla Watt challenges our usual understanding of this outbreak narrative. She encourages us to take a closer look and think about what this predictable trajectory that we're accustomed to seeing in the media and popular culture, what does it maybe hide and what does it obscure from our understanding? So if you think about it, this predictable trajectory that she critiques in this study begins with the identification of an emergent infection, follows it through the global networks of contact and contagion, identifies the zero patient, hopefully, and then ends with the epidemiological work that contains it. So it's a rather optimistic kind of narrative that we're accustomed to seeing. And of course, our current pandemic of COVID-19 challenges it in many ways. So this outbreak narrative runs the risk of dangerously obscuring the complex factors that are at play that make populations vulnerable to disease to begin with. Medical anthropologists like Hannah Brown and Ann Kelly propose an alternative to the outbreak narrative, something that they call hotspot. Hotspot opens up the transmission event to more elaborate temporal and material relationalities that cultivate networks of pathogenic exchange. What they mean to say is that disease risk has to be understood beyond the viral contact alone, and not as a particular feature of a place, like for an example, an outdoors market in China or elsewhere. Instead, it's ecosyndemic, arising from particular configurations of social, biotic, and material conditions through nature cultural corridors where potential pathogenic interactions are most dense. Thus, we know with COVID-19 virus, it has disproportionately affected those people and communities that were already vulnerable. In the US, we saw that virus sweeping through impoverished segments of the population. Now, example from my own fieldwork in Ukraine. The viral spread has overall been quite moderate. However, I want to bring your attention to this last bullet point on the slide. 20% of all cases are among healthcare providers. This is a significant statistic because such high number of cases among healthcare providers has been a reality in Italy, and Spain I think has about 15% cases, but the overall number of confirmed cases in those nations is significantly higher than in Ukraine. To me, this indicates some vulnerabilities among the healthcare personnel that have become more visible as a result of this outbreak. They have been there all along, of course, in the ailing healthcare system in Ukraine that's been waiting for a productive healthcare reform all these years since the beginning of the 90s. And the conversation is finally shifting to demonstrate just how necessary it is to think about healthcare providers as a human resource, and of course as people, as human beings, deserving of the same protections that the general population is. This image, for example, taken from one of the Ukrainian newspapers, shows you one of the healthcare providers on her break, overlooking this abandoned construction site meant to become a new wing of the infectious disease hospital. However, the construction, as you can see, is stopped without much promise that it will ever be finished. This image is just to demonstrate to you the conditions under which the healthcare providers are expected to work in Ukraine. So the public discussions, public discourse about healthcare has finally shifted from this dead point, focusing rather obsessively on corruption or other deficit models, to a more productive focus on what is at stake, who are the major agents of change, and who can collaborate productively to change the system for the better. Here, for instance, you see a slide from Euromaidan Press. It's a Facebook page and a news page that is actually meant for English speakers. And here you see the caption stating, "Good morning world, good morning Ukraine. Kudos to the Ukrainian men and women fighting on 3 fronts. War with Russian mercenaries in Donbass, war against raging wildfires in Chernobyl, grass and forest fires in Zhytomyr Oblast, both still smoldering, and war against COVID-19. This is rather unprecedented, as in the last several decades that I've been doing my fieldwork research among healthcare providers in Ukraine, the popular press coverage of their work has been far from highlighting their heroic deeds, but rather, as I mentioned before, focused on the things that are wrong in the system. I will lean on the recent study that was conducted in Ukraine in the end of April that focused on trying to understand the healthcare providers' evaluation of the quarantine measures in the country and the level of preparedness of their facilities to handle the crisis. This was a large study, over 4,500 respondents currently working as healthcare providers. So this survey demonstrates, among other things, that while the quarantine measures are quite robust and overall viewed by the providers as timely and effective, the evaluation of the state and municipal administration's efforts to contain the virus is quite low, with over 60% of the respondents indicating that it was not meeting their minimal expectations. Judging from other survey questions, with some conversations that I managed to have with the providers in Ukraine in the last months, this is largely due to their understanding of work demands, presenting the levels of risk disproportionate to the amount of the personal protective equipment available, remuneration at work, or even the provider's ability to get transportation to get to and from work. For those of you who are not familiar with this particular site, in Ukraine and elsewhere in Eastern Europe, healthcare providers are not a very well remunerated profession. An average salary of a physician in Ukraine is probably around $200 per month. With some incentives available, and most providers combining several workplaces to make ends meet. So transportation to and from work is a big deal, with most public transportation being suspended during the quarantine. Basically, the ability of providers to get there is highly limited. While the Ministry of Health has announced that they have partnered with various cab services to deliver the providers to work for free, that hasn't happened apparently according to this survey, and providers are expected to arrange for the rides themselves if they don't have a personal vehicle, or drive to work their own personal car if they have such ability. Circling back to what I started this presentation with, it is important to think about how this pandemic experience can be a stimulus for strengthening healthcare sector in places where it is needed, like in Ukraine. This sort of trial by fire during the time of the pandemic brings to light the gaps in the current strategies. Critical medical anthropology points us to yet another question, this one in regards to the international governance structures and whether or not these have been up to the challenge of responding to the crisis of this magnitude. So in Ukraine, there's been a significant disillusionment with the power of international relations to exert a concerted effort to effect positive social change. Of course, here I am pointing to the Russian aggression in Ukraine's eastern provinces. Since Russia invaded Ukraine's Crimea and Donbas regions back in 2014, the forces and their local proxies have killed 14,000 Ukrainians. And this is in comparison to just over 250 deaths of people infected with coronavirus. So this scale is just to demonstrate that there are multiple calamities taking place in Ukraine all at the same time. So the coronavirus is exposing the weakness of today's international institutions, but it might also pave the way for long overdue reforms in these structures. Here I was quoting Andras Umland and Petro Klimkin, who wrote a piece for the Atlantic Council. Another interesting article that I have recently read was co-authored by 3 former U.S. ambassadors to Ukraine, William Taylor, Stephen Pfeiffer, and William Perry, who said that In the midst of damage to public health and global economy, COVID-19 crisis could present an opportunity to resolve this particular war in Ukraine and address the Russian President Vladimir Putin's assault on the international norms of behavior. The three ambassadors, former U.S. ambassadors to Ukraine, are suggesting that the sanctions that have been imposed on our Russian economy are especially meaningful today, where the price of crude oil has been dropping. It's at the 18-year low currently, and fossil fuels account for over 60% of Russian exports. So the looming global recession might just be a sufficient threat for the Russian economy, for the current Russian government to maybe reconsider the negotiations with Ukraine, with, of course, the support of the international organizations and powerful countries like the United States. In this regard, the same article that I've been citing just now says, especially during the pandemic, it is insanity for Russian-led forces and Ukrainians to be killing each other. The Kremlin's aggression must be ended. All nations need to focus now on fighting the coronavirus, not their neighbors. Moving on to the discussion of the interventions that have been shown to work, the prerequisite for successful public health response to any sort of epidemic or other sorts of outbreaks is transparency and trust. These have to be established through effective healthcare system, not during the particular outbreak, but long before any such calamity begins. Overall, anthropologists working in the field of global health have demonstrated that interventions based on horizontal approaches, those that target health needs of the population in a comprehensive way, lead to better health outcomes than vertical approaches, those that target a particular condition or disease alone, like HIV/AIDS or TB, because they acknowledge that people's health needs are, like appropriate nutrition, for example, are comprehensive. So healthcare services and prevention programs worldwide are successful when their goal is to bring health to the people, to empower communities through various health initiatives, to decrease mortality and morbidity through these horizontal efforts that I mentioned. So broad health program focus on alleviation of poverty, not just eradication of a particular disease, with sensitivity to local cultural values and beliefs, and in cooperation with local people. Additionally, partners in health note that solidarity is more essential than ever in times like this. We also know that fear and misinformation about the virus can spread faster than the illness itself, along with xenophobia and prejudice. And Partners in Health is encouraging us to stand against this fear and respond with solidarity instead. We must use our power to uphold human rights and inherent dignity of every single person, they highlight. From critical medical anthropology, we know that fear and misinformation about the virus can distort public perceptions of risk and encourage distrust of health authorities, which can be very dangerous. For people, it might mean barriers to healthcare seeking and further marginalization that can then compromise the susceptibility of populations to infectious disease. So it is very essential to not give way to the fear and misinformation about the virus at this time. To conclude, I will channel Margaret Mead, one of the most famous cultural anthropologists, who was once asked by a student what, in her opinion, was considered to be the first sign of civilization in a culture. The student expected me to talk about fish hooks, clay pots, or grinding stones, but instead she said that the first sign of civilization in an ancient culture was a femur, a thigh bone, that had been broken and then healed. Mead explained that in the animal kingdom, if you break your leg, you die. You cannot run from danger, get to the river for a drink, or hunt for food. No animal survives a broken bone long enough for the bone to heal. A broken femur that's been healed is evidence that someone has taken the time to stay with the person who fell, has bound up the wound, has carried the person to safety, and has tended that person through recovery. Helping someone through difficulty is where civilization starts, Mead said. So solidarity is our urgent goal. Virus is indiscriminate. We have common interests. And perhaps this pandemic has demonstrated that the borders that we erect between nations in the interests of national security might provide temporary sense of security, but it is a false sense of security. The true sense of security is more achievable when your neighbors can enjoy a similar level of stability as you are. Thank you for your attention.